It's really a pleasure to introduce today's keynote speaker for our meeting. And what I love most about today's speaker is not only her brilliance, but also her true and dedicated passion and love of what she does. Today's speaker, Dr. Mattie Castiel, is our Commissioner of Health and Human Services for the City of Worcester. She brings a wealth of professional knowledge and more than 3 decades of experience to her role. In addition to her strong and community-based leadership in the fight against drug addiction and homelessness, she is a board-certified physician in internal medicine and has been medical director to a large municipal EMS system, an ER attending physician, a primary care physician, an urgent care physician, and physician to an elderly outreach program. A Cuban immigrant who speaks fluent Spanish, Dr. Castiel has an MD from the University of California, San Francisco, and a BS in cellular and molecular biology from the Cal State Northbridge. She previously worked as a physician at UMass Memorial Medical Center, the Family Health Center of Worcester, and St. Louis Regional Medical Center. Please join me in giving a very warm Worcester Regional Research Bureau welcome to Dr. Mattie Castiel.
Hi, thank you. Thank you very much. I was wondering who you were talking about, but okay, I remember that it's me. Just want to go over some of the things that we've been doing since COVID and sort of our thought process of moving forward in the community. So for me, it's been a pleasure to be part of the city of Worcester. I've been here now for almost I'm going on 5.5 years, and it's been a new experience for me, but it's everything I've been wanting to do, and in the sense of how do we change what's happening in our community when we're dealing with mental health issues, dealing with addiction, incarceration, homelessness. These are all the issues that I've worked on most of my life, and I look at being able to do it here and being able to put policies together that may change some of the outcomes of what's happening. So first, I'm going to just start by telling you a little bit, obviously talking about racism, but I want to start with the premise, better said by the Spanish philosopher George Santayana. Those who cannot remember the past are condemned to repeat it. We are over a year now in the COVID pandemic, a year where we have experienced so much loss and violence, as well as resilience and collective solidarity. We must work arduously to accelerate the elimination of the unacceptable inequities that pervade our healthcare system and our world at large. As the COVID-19 pandemic has painfully illustrated, these inequities fostered by our society's racism keep African Americans and other racial and ethnic minorities from receiving the accessible, high-quality care that every American deserves. Structural racism, manifested by deep inequities in housing, employment, income, and education, contribute to a greater prevalence of underlying chronic conditions. Racism is the pre-existing condition that was exposed by COVID-19 and exacerbated the deadly impact the virus has had on Black, Brown, and Indigenous communities. So how did we get here? So all major institutions in our country stand on the building blocks of racism. The healthcare system is not an exception. This timeline marks examples of systemic racism and its implications on public health. Because public health includes housing, employment, and overall quality of life experiences, you will notice some events named such as the war on drugs or gentrification. They all have an impact on the community's overall health outcomes. The following examples I'm going to talk about, more specifically how healthcare has historically exploited, oppressed, and marginalized our Black and Brown communities. I first will talk about the American Medical Association, and sort of even our own association, that we are all physicians are part of being part of that membership. Back in the 40s, when Truman wanted to start putting national healthcare systems and national health insurance, they fought against it. As many of you may remember, healthcare was segregated, and Blacks got a truly different form of care than the white community got. And Truman's goal was to have national healthcare. Well, the American Medical Association fought against having that, and they ultimately won. We didn't get national healthcare. Then in the 60s, it came the discussion about having Medicare and Medicaid. And again, the American Medical Association fought against that. And ultimately, it did take hold. But during all of these episodes, our own organization fought against bringing the appropriate, equitable care. So this history continues in a lot of different ways. We know the history about the Tuskegee, which was a study from 1932 to 1972, where researchers with the United States Public Health Service, and they watched Black men who had syphilis develop lesions on their mouth, on their genitals, and they watched and really did not offer them treatment, basically to see what would happen to them. And this is why people don't trust our healthcare system, and that all goes even to what's happening today. Don't trust the vaccines. There was also a well-renowned OBGYN surgeon, Dr. Marion Sims, who has a lot of the Sims retractors that are used in healthcare, in OBGYN surgery. And he performed all kinds of shocking experiments on enslaved Black women without any anesthesia. He would operate on these women about 20 times a day. So this has left people still worried about participating in procedures that require anesthesia. And these communities who've been exploited by healthcare historically are still very distrustful of the system, the procedures to this day. There are also reasons why research is difficult in communities of color just because of this history. So when you see a lot of reports of even when we were looking at the vaccines, making sure that communities of color were part of that process, and you really have to go out and search and get people, convince people to be part of that because people are afraid to do any part of research. So what are some of the health disparities as the outcome of systemic racism? So, and you can see here, for example, Hispanic and foreign-born populations have the highest risks of work-related fatal injuries, or for all cancers combined, the death rate is 25% higher for African Americans, Blacks, than for whites. Black and Hispanic youth ages 10 to 14 are 5 to 4 times more likely than their white counterparts to give birth. And Hispanics are 50% more likely than white counterparts to die of diabetes or liver disease. When we look at this and the indicators of systemic racism as social determinants of health in Worcester, we see that they're equally being affected. So Latinos in Worcester have a poverty rate that's 2 times greater than their white counterparts. In Worcester, the infant mortality rate for Latino and Black women are 3 times and 2 times greater than their white counterparts. 66% of homeless youth in Worcester identify as Latino, Black, or multiracial. And in 2019, Black, Indigenous, and people of color make up 43% of the Worcester's total population, but only 16% of the city of Worcester's full-time employment. So what does it take to achieve health justice? So one of the things that we look at in healthcare, and I always talk about here, because this is where I work. And this is already down at the end of the process. So I work at looking at, smoking, poor nutrition, how do I change their physical activity, violence, alcohol and drugs, sexual behavior. But in order to really have an impact on what I do here, I have to look at what's happening here. And I know you've heard of the social determinants of health, but if we don't improve this, I'm not going to improve this. I'm not going to improve this as a physician. So looking at transportation, at housing, Segregation, that we live in completely different neighborhoods. Schools are very different. You know, we have schools that are based on our taxes, and so poor neighborhoods don't have the same access. Employment and getting people to, you know, to have appropriate jobs. We talk about, you know, that COVID-19 was brought out the inequities in healthcare, and the reality, it's again, it's part of this. And where did most of our people in our community work? They were the essential workers who are out in the community. They were the workers who didn't have a place to, you know, isolate. They're the people who live in multi-generational housing and did not have the ability, as most of us did, to be able to isolate and work from home. But in order even to be a part of this, I think you have to look at the social inequities, look at, you know, our own biases, look at the institutional inequities that exist. What are the policies? What are the policies that happened in the past? All of that from redlining that occurred, segregation, all of those things. And how does that look? How does that look like today? And this is really where we spend, we need to look more preventative, and this is where we spend a lot of our time, is here. And I'm going through this because I didn't go through that before. So when you look at what the life expectancy here in Worcester, living 2 miles apart from one another, if you take, you know, living in the west side of Worcester versus the Kelly Square, there are 11.1 year difference in life expectancy. So the west side has an 84-year life expectancy compared to 72.9. If you look at Worcester Union Hill, you see that the life expectancy is 71.6. This is the lowest in Massachusetts. This is the lowest in Worcester. It's the lowest in our country. It's the lowest in 6 other countries in the world. So something that we talk about is that we say that we're one of the healthiest cities, or Massachusetts is one of the healthiest states in the country. But again, where your zip code is going to tell you that that's not happening in certain parts of our community. So we started this equity task force when COVID-19 hit. It was through the UMass Memorial, through Eric Dixon, and through the city manager of Worcester, Ed Augustus, who really thought about what was happening in our community and seeing our numbers of Latino and Blacks in our community being affected by COVID-19. So we also included community members, because without community members and hearing their voices about what they're seeing, then it's not a true task force. So we have a combination of UMass physicians, UMass providers, City of Worcester, and the community overall. And we decided to look at 4 different groups. One was looking at data, and that's where all of our data, and I have to say, Jean Shershak is the one who does the data, and she is incredible. And you might see some of the data change a little bit because she just updated us recently, and I tried to include it in this PowerPoint. Outreach and education working group is the other one. How do we go into these communities? How do we talk to the people in the community who are fearful of either government, healthcare? How do we reach to them to provide that education so they understand what's happening with COVID and how they can prevent it? And then we started, then we did the testing group, and that actually I was part of the testing group, and I co-led with Cheryl LaPriori this task force, but I also ran the testing working group, which was really looking in the community to figure out how we do testing and how do we bring that access to the community. So between UMass and us, we went into the community, and actually in the different areas in the community that people felt comfortable with, that's where we did the testing in the community. And then the access group. Why are some of the things that keep people from going into hospital or accessing healthcare, and how do we look into those areas, and how do we look to change the inequities that we say that, you know, COVID brought out, but the reality is those who've been working in the field know that this has been going on for decades, and we haven't been able to change it. I just wanted to show you a little bit of data, just how people look at this. So now our positivity rate, and you can see the the areas that here is Worcester, is now 1.52. When the pandemic started, we weren't looking at it in this way. So this is the measurements that are here, and why everybody's in the yellow is because these are multiple tests being done. And so when you have multiple tests being done on the same person, that's going to drop your positivity rate. And so we've now, everything has turned into this, and it looks like we're doing pretty good. Although we know that our numbers are again beginning to increase in our communities due to the variants. So this is the way that we were looking at it initially. And if you can see up here, we started on March 14th, and our positivity rate was 2.88. And part of this, these are individual tests and not multiple tests on the same people. So you get a more accurate look at what's happening with the positivity rate. Back in April, our positivity rate was 34.8. And you can see that we, we're still continuing to do this. And we were always in the red zone, and then we converted into the yellow zone as in the previous slide. But you can see that we went as high as 26.49, and you can see those numbers. This was even in January was, 25.8. And in the beginning of the COVID pandemic, the World Health Organization said that anything above 5, we should really buckle down and think about closing down things in our community. So we certainly did initially here, and now we switched over to something else where we look at all the tests that are being done, and our positivity rate looks a lot less. So where is COVID positivity the highest? And so in the densest neighborhoods is where the positivity rates are. And so you can look at the areas that have the highest positivity. You look at the darker color, and that's where the highest positivity is. And so we're looking at areas of Bell Hill, Pleasant Hill, Chandler Street. And again, these are communities where Black and Brown people live, and these are the numbers of the highest positivity. So the rate of Hispanic positivity in these neighborhoods jumps to 55% in Blacks, to 18% with the white race have a positivity rate of 12% of all cases in these neighborhoods. So one of the measurements that the state uses, and Jean Shershak uses, is looking at the social vulnerability index. And when you look at those same areas, if we go back and look at these same areas in our map, we look at the same issues are happening here. The poorest communities, households are made with folks with disabilities, second languages are here, minority status, housing, transportation. All of these are issues in these vulnerable communities. Again, these same vulnerable communities that have the highest positivity rates. And the highest positivity rates were up here at Great Brook Valley and Bell Hill. And we where we do all our we geared our testing in this area. And then when we switched over, we still do testing, but then focusing more on vaccinations, we go to the same areas with the highest positivity rates to be able to come into these areas and start vaccinating. When we look at who's getting vaccinated, if you look at this area, this is the west side. And again, here's the same areas we've been talking about. So you can see the west side, and the darker colors means the higher vaccinations rates. And so you can see that in these areas on the outskirts are the ones with the highest vaccination rates. And then you look at these areas of Vernon Hill, Maine South, and again, Great Brook Valley are the lowest vaccination rates. And this is where we go mobilely to go into these areas to be able to vaccinate. So what we started to do, and this we do also, and UMass is doing it, is really, and really through the through the state, looking at knowing what the data has been and who has been affected and who we haven't gotten the vaccines out to. How do we change that? What do we do? How do we roll out these vaccines where communities of color are part of this process? Because we know that they're not going to access mass vaccination sites. It is not something that people feel comfortable, and there still is that hesitancy about getting the vaccine. So we've gone to them, we've gone to the shelters, and as you can see, we went to all the different sites of the shelters, and we vaccinated a total of 554. This is how many first and second doses. We've gone to the housing authority and done the same thing and provided vaccinations in the housing authority. We've done 848 total individuals. And then we started on community sites, and we've gone to churches, we've gone to areas where people feel comfortable in. And I have to tell you, like 2 days ago, we did what I always wanted to do. Was actually, I took a group of medical students and my staff, and we went out into the community, and truly, because now we had the essential workers that we can actually go and vaccinate. And we went out there and just vaccinated all the businesses that we could get to, which is what I call really doing public health. And then we're doing a lot of businesses. We're at Imperial today. We've done Table Talk Pies. We've done some at Angelica's. We're going to go to St. Gobain, and we're going to continue going to the businesses in the community. This is the way to get to vulnerable communities, is going to where they are. And so just to get you some of the ideas of how many vaccines that we've administered to so far, which has been 6,438 vaccines to a total of 4,538. We most recently got the pleasure of being able to get Johnson & Johnson, which is that one shot. And we were worried about Johnson & Johnson, thinking that people were going to say, everybody else is getting Moderna and Pfizer, and now I'm getting Johnson & Johnson. But the reality is people feel comfortable with a one shot. And I haven't seen that hesitancy. I know what happened yesterday, and I'm hoping that doesn't change people's minds, but we've been able to do this. And these are some of the places that we've gone to. So again, it reflects the map of where the positivity rates have been. So we've been able to do, Main Street, Elm Park Tower, Belmont Tower. These were through Worcester Housing. We've gone to all of these areas, Journey Church, which is Bell Hill, another high positivity area. We went to the Worcester Islamic Center. And again, all of these are open not only to their congregation, their people, but also to the community. We've been able to do that. We've been to the Ghanaian Church. And again, these are some of the places that we've been to, again, showing the community that we're reaching. So when we're talking about, communities of color and being able to vaccinate, the states, as of April 1st, 6% of vaccines were given to the Latinx community, 5% were given to the Black community, Asian community had 5%, and 72% went into the white community. So when we started at the senior center, and we did vaccinations at the senior center, those numbers started to increase somewhat. So there was 12% Black, Latinx, 9% Black, and 6% Asian. And you can see that the number of white is still here. But when we started to go to them, here's where things started to change, and the numbers started to increase here. Here's Worcester Housing with percent Latinx of 49%, and again, the percent white was 30%. So now you see the white decreasing because they're also accessing it, but we're being able to target to the Latino community. And again, when we've gone to all the community sites, you see that those numbers are increasing here also. So this is the method, this is the target, you go to them. When we look at what the state, this is a percentage of all Massachusetts residents by race and ethnicity. And when you look at the percent of people that have gotten vaccinated, have at least gotten one dose, you see that 72% of the whites have gotten one dose, and 18%, where am I here, of communities of color have gotten vaccinated. So Again, something that the state is trying to work on, something that we're trying to work on. The other thing is looking at the population of elderly who got vaccinated versus over here, that's not the same. Interesting that when we started to vaccinate, we were always going by phases, and we were doing the 75 and above. It was tough to get people who were 75 and above. And if you ask people in the community, they'll say that we just don't live that long. And so that didn't apply. And that's one of Gene Shershak's comments, is that if we really wanted to vaccinate the people that are being affected, we need to look at the younger ages, because that's who's being affected. So again, what makes us healthy? I always show this because I'm hoping that someday we will change our thought process of how we deliver healthcare, and I know we're looking into those. But if and again, that I mentioned in the past that I think this year we're the second healthiest state in the country. But again, mentioning that applies to certain zip codes and not to others. But when we really look at what makes us healthy, so 20% is really healthcare. 20% is genetics, and 60% is social, environmental, and behavioral. So it's housing, it's employment, it's everything that we can do preventative to help people access good health. And we are probably one of the only countries in the world who this is where we don't provide, and we need to provide this. And so what do we think? What is health justice to us? And I know UMass is doing this, and I think your organization is looking at it, and certainly we have a task force in the city to look at housing and investing in particular in chronic homelessness. But housing is an incredible piece that's going to help our community. It's going to decrease the cost of healthcare. Bringing healthcare into the shelters would be ideal, and ultimately at some point eliminating shelters and really just providing housing. And this is where we have to spend a lot of time with. Employment is a large piece, and making sure that people have adequate wages with their employment. Looking at our schools and making sure that funding is appropriate, that maybe not, it should not be based on tax basis, and it should be across the board equitable. Invest in ways that allow young people from the community to see themselves in high-powered and well-paid positions. I think when I was growing up, I think what you learned is that is who's around you and what you see. So in my lifetime, I never saw a physician. I never had a family member who was a physician. Short of seeing a physician when I translated for my parents, it's not what I knew. And I think lots of youth are in this process. And so how do we bring them to be part of what they can be? So obviously equitable healthcare for all, and we need free public transportation. We need to invest in a public safety model that amplifies community voices, centers lived experience, and promotes mental health and well-being. So it's my last slide, and we talk about the GDP and growth in our country, and maybe we should focus on something else besides maybe GDP. Should be looking at housing and employment, and access to food and access to healthcare should be how we measure what our country, what the goals of our country should be. Because when we do this, we leave a whole lot of people behind. And then I'm going to also leave you with this, that people talk a lot about equality. We know that equality is not what we're looking for. We're looking for equity right here. And then ultimately we're looking for liberation, that we actually have this. And what are we going to do as a community? How are you from your organization help to get us here? We've been struggling to get here, and it's been a process. And again, not to leave people behind is our goal. And the social determinants of health is where we need to concentrate in health and to improve the health of all of our community. So thank you. Let me see if I know how to do this now. I'm supposed to stop share, right? Maybe you can do that part for me, because I'm not finding the stop share. Maybe if I escape. No. Paul, can you get me out of here?
If you go down and share screen, Dr. Castiel, you should be able to hit the little caret next to it and turn it off.
Yeah.
Does that help?
Yeah, I know, but I can't find the share screen button for some craziness. Let me, hold on, I'll get my folder. Hold on.
While Dr. Castiel is navigating through the shared screen, I just want to take a moment to thank you for that excellent presentation and really bringing a lot of the issues to light, very informative and really showing us the public health in action.
And perhaps I could just ask a general question, Dr. Castiel. Number one, thank you for such a comprehensive report. And number two, coming out of the pandemic, since we're now at the vaccination stage, how do you see the Health Equity Task Force work continuing past the pandemic? And I think it's particularly notable as such a comprehensive data-driven effort with UMass Memorial Health. So thank you for all the work you're doing in that regard.
You know, one of the things that I would like to see, and I think the partnerships, what the pandemic brought was the ability for all of us to collaborate together. I think that, you know, you look at Worcester Together and groups of people in the community with different organizations who have worked together to solve issues. You know, I look at us working together when we did the testing and doing that together. There's a part of the process of how it's either how we do things or, but we're trying to sustain that piece of working together, because here are some people got some vaccines this way and I can't share my vaccines with other people because I have to, you know, I have to use up my vaccines to, you know, because they gave it to the health department. UMass has their own and they have it, and they have to go through their process in order to get more vaccines. And in some ways, everybody's sort of gone in their own way. So UMass is doing their vaccinations. They're going into the community and doing vaccinations. We collaborate on what sites we're doing, and vice versa. For example, family health, I've offered to, since we've gotten more vaccines, can we share? They just got a huge amount of vaccinations that they didn't have before. But there are processes in place that don't let that collaboration happen. And I guess for me, one of the things that I hope never goes back to the way it was is that sometimes we're more comfortable the way it was, and that's what we know. And I'm hoping that that doesn't happen, that collaboration continues to happen. I hope the groups like, you know, Worcester Together continues to happen. And when COVID is over, these are the things that we have to look back and continue to maintain. Even if sometimes it's against our grain, it's something different than we've ever done. It's listening to others' opinions, it's listening to others' thought process. And I think that that's an important piece to keep in mind when we move forward, that these are the things that we learned and we have to continue to follow through with them.
And thank you, Dr. Castiel. You actually anticipated Patty Eppinger's question about vaccination supply. The other question that just came in is from Jim Leary, who notes he wants to thank you and your team for your tremendous work throughout the entire pandemic and your focus on health equity. His question is related to how all of us as major employers can do over the long term to help address the underlying social determinants of health you outlined that help drive health disparities in the city.
So I think it's, you know, one of the things that I admire UMass for and what they've done, and they've worked, I think, for the last couple of years looking at, you know, blue zones, where we were looking at how to make healthier cities in our country overall. And I know they're focusing on anchoring institutions where large organizations, really any organization, nonprofit organization, or any large organization with endowments, that they use that money to invest in housing, and that we do everything locally. We need to support our own communities. We need to support you know, our businesses. We need to, you know, so we buy locally. We get foods from the restaurants that are in this city, that we support everything, all the mom and pop shops that, and again, use that money for endowment to be able to provide for housing, for employment, for everything that can lift up our community. And that is really healthcare. And I think all of us, if we took that thought process of, I keep saying that, I came to this country, never would I have thought that we would have homeless people in the richest country in the world, right? And we can actually see that here. And it just it should not be happening. And we have all the finances in the world to be able to house people and get people back on their feet and get people employment and be able to, in other words, lift up our entire community. And so by providing housing and having anchoring institutions that UMass is doing, I think is a start that I would love every institution to be doing this. And I know all of you are part of institutions, if not running institutions, that if we focused on our community, it would decrease the cost of healthcare, and what it would do for our community would be incredible.